MAJOCCHI'S granuloma is a topic of discussion. Hello dear students, myself Dr. Maddineni Srinivas. Let us begin the discussion without any further delay. So, dermatophyte are going to produce the fungal infections of the epidermis in the skin. You all know this, but if the same dermatophytes, if they reach the dermis, then we are going to see the presentation which is called as MAJOCCHI'S granuloma. It was previously also called as Granuloma trichophyticum or Granuloma trichophyticum. It was first described by Professor Domenico Maggiochi. You can see this could be asked as a quiz based question related to the images. They may show you the image and you may need to identify who this person is. So, this is Professor Maggiochi. So, by definition, like I have already told you, dermatophytes which will infect the epidermis, if they become invasive into the dermis, they are going to produce deep localized suppurative granulomatous folliculitis and perifolliculitis. This is what is called as Maggiochi's granuloma, right? So, what is the pathological process involved here? It represents a transition from superficial epidermal dermatophytosis into deep follicular dermal inflammatory process. It typically occurs when the mechanical or immunological integrity of the hair follicle is disrupted. So, here remember the hair follicle integrity is very important, both mechanical and also immunological integrity of the hair follicle. What this means, we will see it in the etiopathogenesis. So, coming to the etiology and the predisposing risk factors. So, previously it was commonly seen in the young women over the lower legs who are undergoing mechanical hair epilation. I hope you all know what are the procedures and what are the topical agents which are available which can produce this epilation in the hair which is present in the unwanted areas. But now it has been seen with various other types of presentation also because of the increased immunosuppression which is commonly seen because of the rise of the HIV and also because of the anti-cancer chemotherapeutic agents which will lead to reduced immunity. So, first we will see what are the primary causative agents. It could be Trichophyton and also Microsporum. So, Trichophyton rubrum is the most common organism. Apart from this, these are the other organisms. The fungal hyphae and the arthroconidae, they are going to basically invade the hair shaft, eventually gaining access into the sterile dermis upon the rupture of the hair follicle. So, this is the basic thing which is happening, and you should also remember that at the local level there is going to be some change in the immunity. So, because of the mainly the steroid abuse. So, these patients of Maggiochi's granuloma usually they present with chronic itching, which may sometimes be misdiagnosed as a eczema. And in eczema, what is the usual treatment which is given? It is going to be the steroid, topical steroid. Because of this topical steroid usage, the Maggiochi's granuloma is going to be the presentation is going to be aggravated. We are going to see how is it going to have different presentations in different types of patients. So, frequent and prolonged application of the potent or superpotent topical corticosteroids is one of the main factors to cause the changes in the local immunity. Basically, it is going to suppress the cell-mediated immunity, and also it alters the normal inflammatory response leading to the Tinea Incognito and facilitating the deeper follicular invasion, right? So, and also there is mechanical trauma which could be one of the predisposing factor, like we have already seen the epilation, hair epilation, shaving, waxing, plucking or vigorous scratching because of the excessive itching, which will directly damage the physical follicular wall, hair follicular wall, and allowing the entry of the fungal elements and the skin commensals into the deep into the dermis. We have already seen how the normal flora is going to be present over the skin, that we have discussed in a separate video. I will leave it in the iCard above, right? And also it is there in the playlist. The playlist links are there in the description. So, systemic immunosuppression. So, like I have told you, there are immunosuppressants and also organ transplantation, chemotherapy, and also advanced HIV infection. All these also could impair the T cell function, because T cells are important in cell-mediated immunity. The cell-mediated immunity, because it's getting impaired, there is going to be presentation of the severe form in the nodular or very extensive clinical presentations. So, now coming to the pathogens. So, what exactly is happening here? The MAJOCCHI'S granuloma, it progresses through distinct immunopathologically coordinated phases. So what is happening in each of these phases, we are going to see one by one. So initially there is going to be a follicular penetration. So here what happens is the dermatophytes migrate down the infundibulum into the deeper reaches of the hair follicle. So usually dermatophytes will be present superficially, but somehow they are going to go deep because of the follicular penetration. Later on what happens, those fungi which are present deep because of the rupture of the hair follicle, due to the mechanical trauma or because of the excessive thinning of the skin because of the corticosteroid usage, what will happen, there is going to be distinction and also eventual rupture of the hair follicle. Because of this, what will happen, ultimately the keratin, the sebum and also the fungal elements which consist of immunogenic chitin and mannans, they are going to be directly reaching the sterile dermis, because of which there is going to be a foreign body reaction and also the activation of the immune system in the patient. Because of which what happens is ultimately there is going to be a granulomatous response. How does it present histopathologically? So basically this is a type 4 delayed type of hypersensitivity reaction, that is cell mediated immunity. So initially there will be a neutrophilic infiltration which is going to be called as suppurative phase. Later on it is replaced by epithelioid histiocytes, the lymphocytes and also the foreign body Gyaan cells, right? And there is going to be ultimately a well defined granuloma in the dermis, and that is the reason why this is called as MAJOCCHI'S granuloma. So what is happening? There is superficial dermatophytosis, it will invade the hair keratin, and later on there is going to be trauma or steroid abuse, because of which there is going to be mechanical damage of the skin and also thinning of the skin, and there will be suppression of the cell mediated immunity. Later on there will be follicular distinction, into which the fungi and the spores are going to be present, and there will be distinction and rupture ultimately, which will lead to the release of the keratin and fungal chitin into the sterile dermis. Ultimately there is going to be this neutrophilic infiltration and the giant cell formation, leading to the suppurative and phagocytic responses. Ultimately there is going to be this type 4 hypersensitivity reaction which is going to be mounted against all these contents in the dermis, leading to the granuloma formation. So this is the simple etiopathogenesis. And clinically, how does it manifest? Clinically, you can remember the patient can have two types of broad presentation: superficial follicular form and the deep subcutaneous nodular form of MAJOCCHI'S granuloma. So remember, dear students, in the patients who are immune competent, that is, they are not having any other immunosuppressive conditions apart from the topical steroid usage. So only problem is they are having some kind of a local trauma because of scratching and topical steroid usage. If this is the patient, they are going to present with superficial follicular form of the MAJOCCHI'S granuloma, which is most commonly going to present as erythematous or moderately defined scaly plaques, which are going to be studied by some perifollicular papules and pustules and small nodules. Usually this is seen over the shin, calves, forearms, hands and the face, right? Whereas there is this deeper nodular form, in which case the patients usually will be having some kind of immunocompromised status. It could be like transplant recipients or any malignancy or HIV, okay? Because of which deep seated, firm, fluctuant or boggy subcutaneous nodules, tumor like masses can be seen in the patients. The presentation will be very atypical and gross. You may even think of the possible differential diagnosis of deep fungal infections or maybe some kind of a cutaneous tuberculosis, right? That is how the presentation of this nodular form can be. And what are the sites? It could be scalp, neck, limbs and also trunk. And on the top of this, if the patient is using the steroids, what can happen? The superficial form, lesions may initially appear mild macular erythema, but because of the steroid usage, what will happen? Obviously the inflammation, the erythema will reduce, but subtle follicular papules are going to become more prominent when the antifungal treatment is initiated. This is very paradoxical. Like we have seen a MAJOCCHI'S granuloma patient who is using topical steroids. So what we advise, because it's a fungal infection, so we know that we have to stop the patient using steroids. So we will stop the steroids and we will give the antifungal. Then what will happen during the follow-up, the patient will come back and say, Dr. Saab, you have given me the antifungal, but after the antifungal, the lesion is becoming more and more red in color, erythematous. So you need to counsel the patient before giving the antifungal and stopping the steroids. That yes, dear, yes, patient. Hello, sir. Hello, madam. So we are stopping the steroids, because of which there could be a rebound, or we can say a phenomenon which will lead to the skin becoming more inflamed, because steroids are anti-inflammatory and we are stopping that. So you don't worry, don't uh, feel frightened because of the increased redness which you are able to see. That is just transient, it is going to go away. You need to counsel before stopping steroids and giving antifungals, and also when the patient comes for the consultation. So this counseling part is very important practically. Okay, this is not for any exam purpose, this is practical significance point. Next, coming to the in the nodular form, the inflammatory signs may be minimal or masked, mimicking the soft tissue neoplasms or deep mycotic infections. Okay, so because of the steroid usage, the oral also, maybe the patient is using the steroids, all this in that deep nodular form of the Majoccchi's granuloma, the erythema may be very, very minimal. So because of this, you may think that it is some kind of a neoplasm or deep mycotic infection. So then you are having a feeling that this is Majoccchi's granuloma. So how can you diagnose this condition? So like I have told you, you should have a very high index of suspicion, especially in the patients who are having this his treatment which was pertaining to the eczema. So patient is thought to have eczema, okay, over the leg, is having a lot of itching. So further topical steroids are given, but the condition is not improving and there are some nodules which are seen. So all these should trigger, and you should suspect that probably it could be Majoccchi's granuloma. This should be in your mind. Or like atypical nodular eruptions, if they are there, then also you should suspect. Then what are the investigations you can make, the use with the help of which you can diagnose this condition is obviously the first one, KOH mount. Right, but the problem with the KOH mount is, we know Majoccchi's granuloma is a deeper infection, but we know that initially there is going to be the dermatophytic presence in the epidermis. So if the condition is purely dermal, then KOH may be false negative. That is a problem. But if there is a epidermis showing scaling, or if the hairs, luckily if they are infected and we pluck them and we send them along the scales for the KOH mount, then we can see the septate hyphae and chains of orthoconidia. So this is use of KOH. Next is fungal culture. We can inoculate this into the SDA medium when we are going to see the characteristic colonies. Okay, so this is essential for identifying the specific dermatophytic species and guiding the targeted systemic therapy. But this is not routinely used. KOH can be used, and also the biopsy. Biopsy is the definitive gold standard investigation to diagnose Majoccchi's granuloma, because in the dermis we can see the beautiful granulomas, which are the deep dermal subcutaneous granulomas. We can also rule out the other non-infectious granulomas, that is sarcoidosis and also the deep mycosis, right? And what is the presentation in the biopsy? What are we going to see? Epidermis may be normal or it may show acanthosis. Dermis, we can see, this is a very important, the suppurative and also granulomatous infiltrate can be identified, consisting mainly of the histiocytes and also the multinucleated giant cells. Of course, it is because of cell mediated immunity, so lymphocytes can be seen and also neutrophils can be seen. Follicle may show signs of active disruption and also necrotizing folliculitis, or in the later stages we can also see complete follicular destruction. So to be able to easily identify, we can also make use of some special stains which are PAS and GMS, periodic acid shift, and gomori, methanam and silver, which are going to highlight the fungal hyphae and the spores which are there within the hair shaft or free within the giant cell infiltrating the dermis. So these are crucial for demonstrating the fungal elements when the H&D staining is inconclusive, which is not able to diagnose this. So here you can see in this clinical picture, this is a presentation of the Majoccchi's granuloma. over the lower limbs, you can see there are some small papules which are erythematous. So if you take a biopsy, what we can see, so you can see the presence of the septate hyphae which can be present inside the follicular canal and also surrounding the hair shaft. We can also see the identification of the neutrophils, and also we can see the spongiosis and also the mixed inflammatory infiltrate. All these findings are going to be seen, and obviously the the PAS and the GMS, they are going to help in a clear cut staining of the fungal elements, as you can see in this picture. So here you can see the red arrow pointing towards the fungal hyphae which are stained by the PAS. So next, what is the management protocol? So remember this, though it is a fungal infection, it is a deeper, severe form. So topical antifungals are going to be completely ineffective. So that's why systemic therapy is going to be mandatory. And what is the first line agent which we can use? Yes, it is oral terbinafine. So this terbinafine is going to exhibit high lipophilicity and also keratinophilic properties, right? And leading to excellent penetration into the hair follicles. That is the reason why it is the preferred first line treatment in Majoccchi's granuloma. Before this, you all know LFT should be checked for, and 250 mg OD is the protocol for a period of at least 1 to 2 months, that is 4 to 8 weeks, or maybe even until all the lesions have completely healed. And also you must remember the treatment must continue until the complete clinical and also mycological clearance occurs. So we should not stop the treatment by looking at the clinical clearance of the lesions. We can also use oral itraconazole. It's an alternative. 100-200 mg can be used. You all know that it should be given along with the food to optimize the absorption. And also you should take care that the co-administration of the proton pump inhibitor, which are going to reduce the pH, the acidity of the stomach, should not be co-administered with the oral itraconazole. So that should be one of the criteria. And yeah, this requires acidic gastric environment. So ideally they should be given after the meal. And what is the duration? It's just like terbinafine. Oral griseofulin may also be used. This is a historical, not much of relevance nowadays. Coming to the prognosis and the treatment outcomes which you can expect in this condition. So response to topical therapy, like I have already told you, it's going to be very poor, and we should not give just topical antifungals. We should also give the oral antifungals. So the response to the first line therapy is going to be usually excellent response, and resolution can be seen within 1 to 2 months. And if there are indurated plaques, then doubling of the terbinafine, that is 250 mg BD dose, can be given, and it could lead to the resolution within a period of 1.5 to 2 months. If there is a patient who is having suboptimal response, then what can we do? So highly favorable when switched to an alternative class of systemic antifungal, right? And patients demonstrating this suboptimal response after giving terbinafine completely for a period of 2 months, what we can do is additional 5 weeks of oral itraconazole 100 mg twice daily can be given. So this is what is called as the suboptimal response. Patient is being switched from one treatment modality to the other, usually terbinafine to itraconazole. And prognosis in refractory or resistant cases. So excellent response will be seen with second line systemic agents if the patient is not responding to the first line agents. And extremely recalcitrant cases can be cured with alternative regimens such as the intravenous voriconazole followed by oral voriconazole. So this is also used in the Majoccchi's granuloma, right? And based on the patient status and the immunity of the patient, what is going to happen is immunocompetent patients with localized cell-mediated immunity defects, that is those who are using steroids, steroid paradox we have already seen. In these individuals, the morphological presentation, like we have already seen, it's going to be in the superficial follicular form, and here the prognosis is going to be outstanding if we stop the steroids and if we initiate the treatment with the antifungal agents. But systemically immunocompromised patients, which are going to present very deep nodules, they are going to have a guarded to favorable prognosis. So we cannot say that the lesions may be completely resolved. It may take a lot of time, and also we may need to switch one antifungal to another antifungal to completely treat these patients. So that is going to be the prognosis in these patients. And what can happen if the patient stops the therapy prematurely, or we may stop after looking at the clinical clearance. What can happen? High risk of recurrence could be there, very irritating part both for the patient and frustrating for even the doctors also. So remember, that's why it is recommended the 2-week post cure rule. So what does this mean? So the systemic antifungals must be continued for at least 2 weeks after the complete clinical clearance of the lesions. So this is to take care of the any spores or any fungal hyphae which are present deep in the hair shaft, hair canal, and also deep in the dermis, to kill them. And we have to do extended follow-ups of these patients. It is going to lead to highly durable remission phases, and usually zero recurrence has been observed at 5 months post treatment when the patient is kept at regular follow-up. Okay, so I hope this video was helpful. If so, please do hit that like button, and if you have any doubts regarding this condition or any other condition in dermatology, you can put that in the comment section. And if you are not yet subscribed to my YouTube channel, please do subscribe so that you are going to get awesome videos on a regular basis. Thank you so much. Happy learning. Bye bye.